I'm Enrico Ascher. I'm the co-chairman of the VEITH Symposium, and I'm extremely happy and honored to have Dr. Mark Farber here with us today. Dr. Mark Farber is a well-known interventionist, a vascular surgeon who has pioneered many techniques in the repair of pararenal aneurysms and thoracoabdominal aneurysms. He's the chief of vascular surgery at the University of North Carolina. He's also the program director of the fellowship vascular residency program there. And he is the man who has taught us a lot about endovascular techniques, the advanced one. So whenever we have a complex thoracoabdominal aneurysm or a complex aneurysms, Mark Farber's name always comes to our mind. So I'm very happy to have him today to discuss some of the new innovations that he contributed to and some of the major studies that he's participating of. So Mark, thank you for being here. And I know that you not only organized a tremendous service, but you also were able to get 11 institutions all together under one umbrella and be able to develop something that was unique, which is the communication about complex aneurysms among the different institutions, and the results have been tremendous, excellent. But I also remember that 6 years ago you wrote a paper in Journal of Vascular Surgery saying that the off-the-shelf endovascular prostheses for thoracoabdominal aneurysms and pararenal aneurysms, they were not fit for everyone. You mentioned something between the 20 to 25% only of the candidates. What has happened since then?
Well, you know, when that device was first developed, Enrico, we were hoping that we would be able to treat a lot of patients off the shelf and have something that would fit everyone. But I think that we've learned over the years and dating back many years that not every device works in all patients, and we have to fit the device to the patient. And so for off-the-shelf devices, the approach is that maybe 1 in 4 patients, we have something that we can quickly have for them to treat their aneurysm. And the other 75%, if we were to use that device, there may be some limitations. We may have to take some sacrifice on how it fits and some durability concerns. And we have to weigh that against waiting for a custom manufactured device to arrive and delay the repair. And we have to weigh the long-term outcome and durability versus the short-term benefit about being able to treat them immediately. And that's what we struggle with every day.
So if you have the option between the off-the-shelf and you can wait for the custom-made, at this point today, which one you go for?
So it depends upon the anatomic characteristics. There are some off the shelf that are perfect and you don't have to wait and you have it right in your hand and you're done. There are other off the shelf that say, well, maybe the patient's got some renal insufficiency and I don't want to add some potential added renal risk to the patient who already has some renal compromise because, as you know, renal implications have a huge impact on long-term survival of the patients. And so we weigh those and we do it on an individual basis. If any patient can wait, I prefer a CMD, unless an off-the-shelf is a just as good of a fit, then I would use off-the-shelf because the patients generally want their aneurysm fixed right away, as you know. They don't like waiting around for their repair or their surgery.
Plus sometimes also it's dangerous to wait too long.
Yes.
That's the problem. So I know you are the PI for a very, very large and important study about the Gore excluder thoracoabdominal branch endoprosthesis, the TAMBE study. Can you tell us about some of the early results?
So the TAMBE study is a 4-vessel branch device. Its purpose is to treat type 4 thoracoabdominal aneurysms in the pivotal arm, and we've completed the early feasibility study for that. Based on those early feasibility studies results, we have commenced a pivotal trial in the U.S. and that trial started this summer in July of 2019, and it's anticipated that in the next year to year and a half that pivotal study will complete. Now the pivotal arm is mainly targeted at type 4 thoracos, but there's a secondary arm which we're going to look at type 2 and type 3 thoracoabdominal aneurysms, which, as you know, are more extensive, but that's not the primary endpoints, and that if we can get the device approved for the type 4, then it'll be used more widely, applicable to more patients.
Do you have any question that you think that we should address into this interview?
No, I mean, I think some of the big questions that are coming out today is all of us can accomplish very good early results with endovascular therapy. And if endovascular therapy for aortic disease is going to continue, we need to focus on the long-term durability. And that's going to take people looking at their outcomes and trying to decide about appropriate patient selection and appropriate device use. And I think you're going to see in the next 5 years, as a few devices get approved for complex repairs, that it's going to be more consistent use of which devices are used and less off-label use occurring across the world. And I think that's what we're going to see in the next 5 years.
And it's also important to develop strategies to fix when something goes wrong, right? I mean, those should be made a little bit simpler and also kind of expected that something would nothing lasts forever, correct?
Correct.
So things will degenerate or they change, or even the anatomy changes in the body with time alone. So I think that if we can develop more strategies at the same time we're developing these devices, we're also thinking, what would happen if this happens? And then have a whole armamentarium of strategies that we can address the issues. I think that would make people more comfortable that the long-term results will be okay.